Hello friends, welcome to my channel Clinical Biochemistry by Dr. P.K. Prabhakar. Today we are going to talk about liver function test. As the liver function test is a large unit, so we are going to divide whole liver function test into three different sections. So we will upload three different videos on liver function test. So all the test which is coming in the liver function test will be divided into three parts. So before going to see what is liver function test and what are the different tests we are going to perform, we should understand some basic things about the liver. As liver is one of the most important organ of our body, which perform a huge number of different type of functions, which is essentially required for my body. So for our survival, we require the normal functioning liver. If we are having any kind of abnormality in those livers or any major portion of the livers, those functions will be if liver will not perform their normal functions, so certainly it will affect our normal physiological homeostasis or different kind of parameters in our body. So liver is one of the largest internal organs, and roughly its weight will be 1.5 kg, roughly 1500 grams, and it is of 1.5 kg. So externally we are having largest organ, that is skin, but inside our body in a systemic organs, liver is one of the largest internal organ we are having. The place of liver in our body is it is located at upper right quadrant and just below the diaphragm. Diaphragm is normally a hypothetical place which is going to segregate abdomen regions from the chest regions. The liver contains two different lobes, which is divided by the falciform ligament. As you can see here, this is called falciform ligament. So roughly, liver will have two different visualized means by if you'll see the visuologically from the external side, it will looks like two different segments, both of which are made up of 8 different segments. So both the lobes are having roughly 8 different segments. Physiologically means internally, if you see the cellular structures and their internal components, so both these lobes does not have any kind of differences. So physiologically, by functions, both the lobes and all the 16 segments is having same functions. So functionally, there are no difference in any portion of the liver. Now, these segments are made up of normally thousands of lobules. We will see what is the lobules and what is the basic structure of lobules. So these 8 different segments of this left lobe and 8 different segments in the right lobes. All those lobes will have different lobules. Like in case of lungs, we are having alveoli and alveolus. Similarly, here we are having lobes and lobules. These lobules are connected to a small ducts. So from each lobes, all the secretions will be collected into small ducts, and those small ducts will be collected together into the large duct, and finally that is going to form a common hepatic duct, which is going to take all the waste product, all the secretory products from the liver to outside the liver. So basically, this is the how different kind of blood or different secretions is going to into the liver or out of the liver. So roughly, we are having two sources of blood in the liver. In our body, one liver is the only organ which receives blood from two different sources. One from the heart, that is through hepatic artery, which is roughly oxygen-rich blood. It is having because from lung blood will go to the heart, and from heart it is coming to the lung. So that is through hepatic artery, that is oxygen-rich blood. And second route by which blood comes to the liver, that is called a portal vein, which directly come from GIT tract. So that is all the food content, whatever we eat, anything which is coming into a GIT tract, before those content, those dietary product, dietary substances going to the other tissue, it has to go to the liver for their evaluation, for the detoxification process. So those content which is we are going to absorb in the GIT tract, they will go to the liver through this hepatic portal vein. That is mainly nutrient rich blood. So these are the two routes. Otherwise, normally in most of the organs, you can see one artery carry blood from heart to the tissue, and from tissue, blood will be carried to the heart by the veins. But in liver we are having two source of blood, one from digestive systems, that is through portal veins, and one from the heart, that is through hepatic artery. There are two other routes also there, which carry the secretions from the liver outside. Yeah, blood from liver to outside. So two routes are there, two things are there. One route is that which carry the all the blood, either these blood which is coming from the hepatic portal veins or which is coming from the hepatic artery. So both the blood, this blood and this blood will come merge at a specific place. That place we are going to call sinusoids. We will see that one, sinusoids. So both the blood will be merged together, and once it will finish their functions in the liver, so those blood is going to exit from the liver and goes to the different other places or into the heart, that is through hepatic vein, which is oxygen and oxygen deficient blood, means all the oxygen which has been used in the liver. There is other routes which collect all the secretions, bile pigment, bilirubins, and they are secreted from the liver into the gallbladder or into the duodenum, small intestine, via bile duct, or finally it will be through common bile duct. So two routes for incoming of the blood. One is through portal vein, the second one is through hepatic artery. Two things, two major capillary, or you can call vessels, which exiting from the liver, that is hepatic vein and the bile duct. All the blood which is coming to the liver, that 20% portion of blood which reaches to the liver is coming from the heart, and 70 to 80% of blood which is reaching to the liver is through the hepatic portal veins. So maximum blood, roughly 3 to 4 times of blood is come for, means you can call it 66 to 75% of blood coming from hepatic portal veins through digestive systems, and one third to one fifth blood coming from the hepatic artery through the heart. This liver receives 25% of the total resting cardiac output, means whatever your heart is going to pump blood, means heart pumps blood. So 25%, roughly one fourth of blood is coming to the liver. So one fourth of total blood which is pumped by liver, heart is going to the liver. That is 25% of the cardiac output, and it is going to use roughly 20% of the resting oxygen consumption. Means if my whole body is going to use whatever oxygen, one fifth oxygen will be used only by the liver. So blood it receives one fourth of whole body, and oxygen it receives, it consumes roughly one fifth. This is the picture of one of the lobules, which forms the different lobes of the hepatic, means the liver. This lobules is normally hexagonal in the shape. If you see, this is hexagonals, and each corner of this lobules will have a portal triad. Like here you can see. So all the six corners. This is one corner. This is second corner. This is third corner. This is fourth corner. This is fifth corner. This is sixth corner. So this is a hexagonal, like a honeycomb like a structure. It is hexagonal in shape, and it is at the corner of each hexagonal it is having a portal triad. We are going to see the portal triad also. Normally in the livers, hepatocytes, in the liver we are having two major type of cells we can see here. Those two types of cells are, one is hepatocytes. Roughly you can see these are the major, which is yellowish cells. They are hepatocytes. Roughly seven, sorry, uh, roughly it is 70% of the total liver cells. Yeah, whatever cells liver is having, they are hepatocyte cells, hepatocytes, and 20 remaining cells are Kupffer cells. Kupffer cells are nothing, it is a macrophagic cells which is matured in the liver. So matured monocytes which is going to be matured in the liver, that is called macrophagic cells, and this is, it is having a specific name, that is called as Kupffer cells. This 70% hepatocytes, they are regenerative in nature. Means if we are having any kind of damage in some portion of the hepatocytic cells, those cells can regenerate themselves. So hepatocytes is having one of the important property, that is called a regenerative property. it can regenerate by themselves. And these hepatocytes are responsible for most of the important functions performed by liver. So whatever function is done by liver, most of the functions will be completed by hepatocytes. And the Kupffer cells are, as you know, that is a macrophagic cells, and macrophagic cells means it is a phagocytic cells which do engulf any kind of pathogenic substance, any kind of foreign substance, any substance which has to be removed, which has to be degraded. Those things will be taken by Kupffer cells, and lastly it will be degraded. Now comes to the lobules structures. These lobules are honeycomb-like structure which is having 6 sides and 6 corners, and at each corner they will have a portal triad, as you are going to see here. This portal triad is composed of 3 important things. One is hepatic artery, second one is hepatic portal vein, and third one is bile duct. These three veins is having three different capillaries having their own significance. This hepatic artery carry all the bloods which come into the liver from the heart. So hepatic artery carry blood from the heart. Portal vein carry blood from the digestive systems. So blood which comes from the heart and blood which comes from the digestive systems, they are going and merge at a specific place into the liver. That place we are going to call sinusoids. I have already told at this junction, at the sinusoids, both hepatic artery and portal veins are going to merge together. So this hepatic artery and portal veins carry blood towards the center, from like this one towards the center. It is going to carry the blood. Whatever secretion, whatever things will be, whatever liquid is going to flow in this one, they are going to carry them towards the center. And the third capillary, third vehicle means that one is there, which is called bile duct. This bile duct collects all the secretions from different cells, different portion of the liver, through a small duct, and a small duct give large, makes large duct finally makes bile duct, and those bile duct makes hepatic duct, and finally it will be going to merge into common bile duct. So this bile duct normally, the flow of bile duct will be away from the center, means it is moving outside, because it is going to carry the bile pigment, bile salts, and other components, other secretory things which is coming from the liver. The special feature, if you'll see here, uh, this is again zoomed picture. I will show that one also. The special properties of the sinusoids, which where both hepatic artery and the portal vein is going to merge. Like this is here you can see this is hepatic portal veins from which digestive system, from digestive system this portion is coming. This is hepatic artery from heart. This blood is going to come. These two are going to merge at a specific place that is called sinusoids. So this is the place which is called sinusoids. So in these two cases, blood or the content liquid which is flowing in this one, that is moving towards the center, whereas this is the third portion of the portal thread which is called bile duct. The bile duct normally collects all the secretions, and the movement of the flow of the bile duct in the bile duct is away from the center. In this fenestrated, this is because this is a capillary. Sinusoids are a place where both artery and hepatic veins are going to merge. So here we are having endothelial cells. This endothelial cells is having a specific property that is called as fenestrated. Fenestrated means it is sieved. It is having a pores, means large. The gap between two endothelial cells are slightly bigger, so that easily component can be given to the hepatocytes. So they are called as fenestrated. Fenestrated means sieved pored endothelial cells. That is the special feature of the sinusoidal cells, sinusoidal membrane cells, endothelial cells. So this is a basic anatomical structure of the livers and the lobules. Now if you see the liver's functions, liver is going to perform one of the busiest organ of our body. Liver is going to perform number of functions. Number of function means from the synthesis to the degradations, from the storage to the excretory. So it is going to perform a lot of different type of functions. Means you can divide those functions into different ways. Like we will see 2 3 different ways. First, it is going to involve in the metabolic process of the carbohydrate. Like other cells, liver is going to involve in the carbohydrate metabolic process, like glycolysis will occur, glycogen synthesis will occur, glycogenolysis will occur, means glycogen degradation will happen. Then gluconeogenesis is going to happen, means synthesis of glucose from the new sources, and HMP shunt is going to happen in the liver. The major functions in terms of carbohydrate which does not happen to other places are whatever surplus amount of glucose we are having, like we are going to eat, and if we are having surplus amount of glucose, those glucose is going to be converted into either glycogens or into the triglycerides. So majorly it is going to convert it into glycogen in the liver. So liver stores in the form of glycogens the extra glucose. That is one of the major function in terms of carbohydrate metabolic process. When we are going to see the metabolic process in terms of proteins, so a lot of different types of protein is also going to be synthesized by liver. Like proteins are not only synthesizing proteins also involved in the metabolic process of amino acids. Like it is involved in urea synthesis, because ammonia we are need to remove, and ammonia is water insoluble, so we need to remove it. So ammonia has to be converted into urea. So that conversion will be done by in the liver only. So that is another function. Other than this one, liver also involved in number of other protein synthesis functions, like non-essential amino acids. Essential amino acids are those amino acids which we get through the diet, but non-essential amino acid we need to synthesize. We have to synthesize in our body only. So liver is involved in the synthesis or production of non-essential amino acids. Liver also involves in the formation or synthesis of number of important proteins which is going to occurs in our body, like almost all the clotting factors. Roughly we are having 14 clotting factors, and most of the clotting factors are going to be produced in the liver. Other than clotting factors, complement proteins. Complement system is one of the most important system of our immune system, which is part of both innate and adaptive immune systems. So roughly complement system requires 30 to 35 different proteins, and most of the proteins are going to be synthesized in liver. Not only clotting factor, not only complement systems, most of the acute phase proteins is also going to be produced into the liver only. Then liver is also going to responsible for the transferrin, which is protein which is required for the iron movement, iron transport. It is going to form liver are responsible for hepatocytes are responsible for the lipoprotein, and those lipoproteins are responsible for lipid transport from the liver to the peripheral tissue. Then it requires for the globulins for immunological functions, and albumin for oncotic pressures and the transportation proteins. This is in terms of proteins. If we are having any defect in protein synthesis, we are having a lot of different functions, different abnormalities, like we can have bleeding disorders, we can have excess bleedings, we are having ascites, we can have impaired immune functions, we can be anemic, or we can have fatigue. These are different abnormality related to proteins. Then liver is not only responsible for the carbohydrate and protein function, but it is also responsible for involved in the lipid metabolic processes. So number of lipids whose production and synthesis is going to be happen and managed by liver, like triacylglycerols or triglycerides, phospholipids, lipoproteins, cholesterols, acetyl coenzyme A, other than this one, number of other fatty acid synthesis, ketogenesis, cholesterol synthesis, and their excretions, bile acid synthesis. In terms of vitamin D synthesis, 25 hydroxylation during vitamin D synthesis. So all these functions are related to lipid metabolic process, which is going to happen in the liver. So these are different metabolic properties, metabolic functions. Other than this one, it is also responsible for the steroids, hormones, and the peptide hormones, metabolism, and the excretions. Then these are the synthetic functions. Other than these synthetic functions, liver is also responsible for the storage functions. So liver stores number of components, like most of the metal ions like zinc, iron, copper, magnesium. They are going to be stored into the liver. Not only this one, liver also stores glycogen, vitamin A, vitamin D, or all the fat soluble vitamins A, D, E, K, and vitamin B12. So these are the storage function of the liver. Other than this one, liver is responsible for some other important functions like bile or bile pigment synthesis, conversion of carotene into vitamin A, conversion of folate into 5-methyl tetrahydrofolate, conversion of vitamin D into their active form, that is 25-hydroxycholocalciferols, and urea cycle, that is conversion of ammonia into urea. So this is some of the other important functions for the synthetic functions. Then liver is also responsible for the metabolic processes of detox and detoxification of xenobiotic molecules. What is xenobiotic means? Means any compounds which is undesirable, uh, which we don't require in a normal healthy human being. So those components has to be removed after their functions has to be done, or if it is non-utilized, unutilized, it has to be removed by our body. So like medicines, steroidal hormones, non-steroidal hormones, insulin, growth factors, chemicals, toxin, poison, pesticides. So all those things needs to be removed from our body. So that process is called as detoxification process, or in scientific terms, we are going to call it biotransformations. Then liver are also responsible for some of the protective functions. It is involved in excretory functions. So these are different types of functions which is performed by liver. So if you are going to categorize the function of liver, we will have these six different category like secretory functions, where liver is responsible for secretion of some of the bile acids from the cholesterol, conjugation of the bilirubin, and bilirubin will be excreted. Then excretory functions, excretion of some of the dyes like bromosophthalene and rose bengal blue. Then metabolic process of carbohydrate, lipid, amino acid, cholesterol, ammonia from the anion, mineral metabolic process, vitamin mineral metabolic process, nucleic acid metabolic process, or conversion of sugar from one form to other form. These are all metabolic processes. Then, if you see the synthetic functions, liver responsible for number of albumins for the transportations, for other immunological functions, for oncotic properties. Liver responsible for clotting factors. Liver is responsible for complement system proteins. Liver responsible for transport proteins. Liver responsible for immunological proteins. So that is their synthetic properties. Detoxification for xenobiotics, hormones, protein hormones, and some of the other metabolites. Xenobiotics includes toxins, poisons, pesticides, and other undesirable, unwanted chemicals. And last function is storage function. Glycogens, mainly fat soluble vitamins and vitamin B12, and plus trace minerals, trace elements. So this is the function. On the basis of these functions, if we want to see which type of function liver does not perform, so we need a specific type of test for which will give me that liver is not performing this type of test, this type of physiology, this type of function is not going to perform by liver. So for every specific functions, we are going to have a specific type of tests. So similarly, for we are having six different functions: secretory, excretory, metabolic, synthetic, detoxification, and storage. We are going to have a specific type of test for these different functions. So if we want to see the liver secretory function is working or not working, we can go for serum bilirubin test, urine bilirubin test, or urine urobilinogen test by Van der Waals reactions, Van der Waals test. So we are going to see today these three tests. Then we can have some of the tests for excretory functions like BSP retention test and Rose Bengal blue test. Then for metabolic functions, we can go for galactose tolerance test, fructose tolerance test, cholesterol concentration or different lipid estimations, blood ammonia level estimations, and glutamine level in the cerebrospinal fluids. If you want to see metabolic functions. If we want to see synthetic functions, measure the synthetic function of liver, then we can go for total albumins or proteins or AG albumin globulin ratio or serum fibrinogens or prothrombin time index measurement. If we want to see detoxification performance of the liver, then we can go for hepatic acid test, MEGX test or antipyrine breath test. And there are number of enzymes which is going to be produced by livers. Those enzymes are also working as a diagnostic tool for number of diseases. So that is enzymes. So there we are having SGOT, SGPT, alkaline phosphatase, GGT, then 5' nucleotide and lactate dehydrogenase. So these are some of the enzymes, clinically significant enzyme you can call it. So today we are going to see bilirubin, uh, uh, serum bilirubin, urine bilirubin, and urobilinogen test. How to going to we will perform. So this today we will finish these three tests. If hope you are able to understand it. If you have any query, any comments, you can write in the comment box. You can pause the video. You can see it. You can listen several times. Now, come to serum bilirubin test. Serum bilirubin is a byproduct after the metabolic process of RBC. So normally we know the RBC is having normal lifespan of 120 days. So after 120 days, RBC is going to be degraded either after the completion of their normal lifespan of 120 days or during the erythropoiesis process if some of the RBC has been synthesized which is abnormal RBC. Some RBC is going to be degraded, killed or hemolyzed because of different kind of infections or different kind of toxins. So all those RBCs are going to be degraded, metabolized in the spleen, not exactly Kupffer cells, it is in the spleen macrophage of the spleen. So RBC does not. If you we know that RBC does not have anything. RBC is having only hemoglobin in their cell. They don't have neither nucleus nor any kind of cellular organelles. So once you are going to metabolize RBC, we are going to get hemoglobin mainly. This hemoglobin will is going to composed of two component heme plus globin. Globin is a protein component and heme is the porphyrin ring containing iron center. This globin is going to be metabolized further and ultimately we are going to get amino acid and this amino acid will be used as a for protein synthesis, recycling or for other purposes as a nitrogen sources. This heme which is a porphyrin ring containing iron centers, this is further going to be metabolized and iron will be separated and bilirubin is going to be product via one of the intermediate that is called as bilirubin. This bilirubin is going to be excreted, mediated by liver, gallbladder, intestine, then through either through a stool or through urine, it will be excreted. And this iron will be stored and transported to the bone marrow for recycling for new blood cell synthesis. This is the normal basic how RBC is going to be metabolized. Now we'll see how bilirubin is going to form in the details and how it is going to be excreted. So whole bilirubin excretory process we are going to divide into three different phases. First, it is going to we are going to talk about the production phase of bilirubin. So I have told you that RBC is going to be degraded, and the degraded RBC is going to give us hemoglobin. So roughly in the hemoglobins, we are going to get 70 to 80% hemoglobin and 20 to 25% other heme protein like myoglobins or cytochromes. We are going to get it. So once it will be metabolized, so we are going to get heme and globin. Globin is further going to be metabolized and give you amino acid. So here we are going to have heme, which is iron containing porphyrin ring. Now this heme daily we are going to get 250 gram to 400 mg of heme is going to be metabolized. Now this heme is going to be converted. All these processes is going to happen in spleen. So this process is going to occur in spleen macrophagic cells. So this heme is going to be converted into biliverdin by an enzyme that is called as heme oxygenase. It requires three oxygen oxygen molecule atom, and iron will be removed from the heme, and finally carbon dioxide will be there. So this iron will be going to combine with apoferritin and finally gives you ferritin. So that is the fate of iron. The ring portion, porphyrin ring portion, is going to be converted into biliverdin, and this biliverdin is finally going to be converted by biliverdin reductase to bilirubin. Now this bilirubin production or synthesis happens in occurs in the liver, spleen. Now this bilirubin is water insoluble, so we need to convert them to the water soluble component so that it will be easily removed from my body, because bilirubin is not useful for my body. We don't want bilirubin for any other activity. It needs to be removed. So for this removal, bilirubin has to be transported to the liver. The route by which bilirubin will be transported from spleen to liver is through blood circulation, and blood is composed of water. So till you are going to make bilirubin water soluble, it cannot be transported from spleen to the liver. For this one, bilirubin is going to be associated with albumin, which is present in this blood circulations. So bilirubin albumin complex, now it will be water soluble. This bilirubin albumin components together are going to the liver. So bilirubin albumin component from spleen comes to the liver. In the liver, in the hepatocytes, this is the shaded portion is hepatocytes. So here we are having one of the important reaction, that is called conjugation reactions. Conjugation means addition of a certain functional group, certain groups of molecules. So here albumin is going to be detached, as bilirubin is going to be welcomed or going to be received by a specific protein in the hepatocyte. That's name is ligandin. So ligandin is a protein which receives, which accept bilirubin from albumin bilirubin complex, and bilirubin albumin will be left out in the circulations, and bilirubin has been taken into the hepatocytes. So we are having ligandin bilirubin combinations. This bilirubin will be released from there, from the ligandin, and ligandin will be recycled for next process of the next phase of reactions. This bilirubin is going for glucuronidations, means glucuronic acid, UDP glucuronic acids or glucuronate will be added to the bilirubin. The purpose of this addition is to make bilirubin water soluble, because bilirubin, as you know, that it is water insoluble, we have to make them soluble. By adding this UDP glucuronate molecules, we will make them water soluble. So there are two molecules of UDP glucuronate is going to be added to each bilirubin, but not at a time. One molecule of UDP glucuronate will be added one time, first time, then after the addition of first, it will be converted into bilirubin monoglucuronide. Then second molecule of UDP glucuronate will be added, and it will be converted to bilirubin diglucuronide. But these two reactions, both addition of glucuronate will be catalyzed by a specific enzyme that is called as UDP glucuronyl transferase. So now bilirubin is going to be converted into bilirubin diglucuronide. Now this is water soluble. This reaction is called as conjugation reactions. Now this conjugation reaction does not take place for almost all the bilirubin. Roughly 70 to 80% of bilirubin is going for conjugation. 20 to 30% bilirubin is left unconjugated. Conjugated bilirubin means it is water soluble. Unconjugated means which is water insoluble. Now whatever bilirubin we have got here in the diglucuronide forms, that will be transported from liver to the bile duct and up to the gallbladder, and from gallbladder to the duodenum or intestine. So that is third phase. In the first phase we have seen here, we have only bilirubin which is unconjugated, means this is water so insoluble bilirubin only. Here in the liver we are having both water soluble as well as water insoluble bilirubins, but major portion are water soluble. Then this bilirubin glucuronide, which is coming out of the liver to bile duct and going to the gallbladder, that is going to call it excretion of the bilirubin. This bilirubin glucuronide from bile duct through common bile duct, it will reach to the intestine or the duodenum. In the duodenum, bacterial enzymes removes those glucuronide molecules which is added in the liver during conjugation reactions. So ultimately we are going to get bilirubin by bacterial enzymes. Again, some bacterial enzymes convert this bilirubin into urobilinogens. This is the uh, precursor of the colored compound. This urobilinogen is having two fate. Either it will be retained into the intestine or it will go to the kidney. Most of the bilirubin, roughly 80 to 90% of the urobilinogen, is going to be retained into the intestine and converted to stercobilinogens by bacterial enzymes, and same bacterial enzymes is going to convert stercobilinogen into stercobilins. The color of this stercobilin is gray, and this stercobilin's gray color normally gives the normal color to the stool or feces. So the normal color of stool is gray because of this stercobilin. This stercobilin we get from stercobilinogens, which we get from urobilinogens. This is the normal color what we are having in the stool. The remaining 10 to 20% of urobilinogens, through circulation it is going to the kidney, and there it will be converted into urobilin. This urobilin's color is yellowish, and this yellowish urobilins normally gives the yellowish color of the urine. So urine is having a specific color which is because of urobilin, and the feces or stool is having the normal gray color, that is because of stercobilin. So only conjugated bilirubin is coming out of the liver into the bile duct and gallbladder and then into the intestine. So this is the overall metabolic process of bilirubin, how it starts from RBC degradations, RBC metabolic, and how it ends with excretion in the form of urobilin and stercobilin. Now, if you see the normal concentration of bilirubin in the, so we are having total two different types of bilirubin, that is conjugated and unconjugated. If we are going to merge both, mix both, cumulate both, so we will get total bilirubin. So the normal total plasma bilirubin is roughly 0.2 to 0.6 mg, 0.8 mg per dl. Out of this one, unconjugated bilirubin is roughly 0.2 to 0.6 mg per dl, and conjugated is 0 to 0.2 mg per dl. If the plasma bilirubin level exceeds 1 mg per dl, normal level is less than 1.8 mg only. So if normal plasma bilirubin is going to increase by 1 mg, more than 1 mg per dl, the condition is called as hyperbilirubinemia. And if level rises between 1 to 2, it is indicative of the latent form of jaundice. When the bilirubin level rises 2 mg per dl, it diffuses into the tissue and giving the yellowish coloration to the different portion of the body, like skins, sclera, conjunctiva, mucous membranes. So this ultimately we are going to call it jaundice. So jaundice is not a disease; it is a kind of symptoms where bilirubin is increased into the secretions, and that normally gives the yellowish color to the different portion of our body. Now, this bilirubin is going to be measured by a specific test that is called as van der Waals reaction. This van der Waals reaction is nothing, it is a reaction where bilirubin reacts with a specific chemicals. That chemical's name is diazotide sulfonilic acid. So sulfonilic acid, which is diazotide, reacts with bilirubin and gives us a colored compound that is called as azobilirubin, that is of purple color. So the principle of this test is diazotide sulfonilic acid reacts with bilirubin, gives a purple color azobilirubin, and that azobilirubin we are going to measure it. This diazotide sulfonilic acid we are going to call diazo reagent, or it is called as Ehrlich's diazo reagent. Every time whenever we are going to perform a test, we are going to fresh prepare this reagent. So this reagent normally a combination of two different solutions, solution A and solution B. Solution A contains sulfonilic acid in concentrated hydrochloric acid, and solution B contains sodium nitrite. So when we are going to mix these two in a specific ratio, that is 10 ml of solution A and 0.8 ml of solution B, before the test. So every time before every test we need a fresh preparation of combination of these two. So these two you need to combine, mix together during just before your test. What is the test, how we are going to perform? So if we are going to have a serum bilirubin, or we are going to have a test sample, this test sample may have bilirubin either conjugated or unconjugated or both. So this bilirubin is going to react with this diazotide sulfonilic acid, and it will give us, if azobilirubin, Azobilirubin means it will have pink or purple color. It means the what, because this reagent is going to be prepared in water only. So only water soluble bilirubin is reacting here. Means only conjugated bilirubin has been reacted here. So this reaction is only because of conjugated bilirubin. Now there are unconjugated, there might be unconjugated bilirubin also possibly in these test solutions. So, and unconjugated bilirubins are water insoluble, so we have to make them soluble. For that one we are going to add activator or accelerator. Normally this accelerator is methanol. Methanol, which is an organic solvent. So this organic solvents solubilize your indirect bilirubin or unconjugated bilirubin and make them water soluble, and then unconjugated bilirubin, which becomes soluble, is going to react with the reagent and gives you color. So color will be intensified. Whatever color was here, if unconjugated bilirubin will be there, so color will be more intense after this addition of activator, because now unconjugated bilirubin also is going to react. So color has been intensified, and that color we are going to measure at 600 nanometer. So first reactions, this reaction occurs within 30 seconds, and the second reactions roughly takes 30 minutes. So the reactions which occurs instantly after the addition of diazotyl sulfonilic acid gives us the information about conjugated bilirubin, and the color which is going to increase or intensify after the 30 minutes, that gives us information about unconjugated bilirubin. So there are two phase, you can see there are two reaction occurs in two phase. This is one phase, so this is first phase, and second phase is after the addition of activator. So it might be possible either we are going to have only first phase reactions, or we can have only second phase of reactions, or we can have both phase together. So when we are having only this color productions, there will, after the addition of accelerator, no intensification, no color will be intensified, means only conjugated bilirubin was there, that is there. If so, it, we are going to have only this one, it means only direct reaction. This is called direct reaction without the involvement of any activator. So direct reaction means conjugated bilirubin. Direct reaction means conjugated bilirubin. If we don't have any kind of color production here during the, after the addition of this one, but once we have added activator or accelerator or methanol, the color has been produced, means no direct reaction, only indirect reactions. So indirect reaction, why it is indirect? Because we have added activator and then reaction happens, so it is called indirect reaction. So if we are having only indirect reaction, means we are having unconjugated bilirubin. But it might be possible that there will be color production here, and those color will be intensified, more deeper color will be there after the addition of activator. So some color has been produced here and some color has been produced here, so both phases we are having color. So color production occurs in two phases, one phase and two phase. So this type of reactions where both phases going to give you color, it is called as biphasic reactions. So that is explained here. Van der Waals reaction reacts with the conjugated bilirubin and gives a purple color immediately, that is normally 30 seconds. This is called as direct positive reaction, and this is only for the conjugated bilirubin. Addition of methanol or any other organic solvents dissolves the unconjugated bilirubin and gives the van der Waals reactions normally within 30 minutes. Here it was 30 seconds, here it is 30 minutes, means after certain time. This is called as indirect positive, and this is only positive for the unconjugated bilirubin. If the serum contains both unconjugated and conjugated bilirubin in high concentration, the purple color is produced immediately. That is because of direct reactions, which is further intensified, means color becomes deeper by the addition of alcohol or methanol, that is indirect. So we have direct also, indirect also. This is called as biphasic reactions. So if we can have only direct reaction, means it means we are having only conjugated bilirubin. If we are having only indirect reactions, it means we are having only unconjugated bilirubin. If we are having both biphasic reaction, means we are having both conjugated and unconjugated bilirubin. So this conjugated bilirubin is also called as, because it gives direct reaction, so it is called as direct bilirubin. Unconjugated bilirubin, because it gives indirect reaction, so it is known as indirect bilirubin. So we have direct bilirubin or indirect bilirubin, or conjugated bilirubin or unconjugated bilirubin. Now, so how big bilirubin level will be rises, how jaundice is going to happen. So there might be three different kind of possibility by which bilirubin level may rise. Either we can have more degradation of rbc, more rbc lysis, like uh, anemia is there, like malarial parasite infection is there, like sickle cell disease is there. So in those cases, more rbc will be lyzed, more hemoglobin will be degraded, and more bilirubin will be produced. So in those conditions, the more bilirubin level rises because of more rbc degradation. So this is just before the liver, means bilirubin reaches to the liver. Before that one, we are having higher level of bilirubin. So this abnormality which occurs before liver is called as pre-hepatic jaundice. So if we are having more bilirubin level in our body, but the abnormality is not exactly in the liver, it will be before the liver. So that is called as pre-hepatic jaundice. And this is also called as hemolytic jaundice. Why? Because it is caused due to hemolysis of RBC. That is one type of jaundice. Second type of so in the case of hemolytic or prehepatic jaundice, we are having only bilirubin, that is unconjugated bilirubin. Means we are going to have only unconjugated bilirubin. Means we are going to have only indirect bilirubin, and that bilirubin will give you only indirect positive test. Second type of jaundice is when we are having any kind of abnormality in the conjugation process. So liver is not able to do proper conjugation reactions. So in that case, we will have both conjugated bilirubin and unconjugated bilirubin level rises. So that is because of defect in the hepatic cells. So they are called as hepatic jaundice or hepatocellular jaundice, where the main defect in the hepatic cells. So in this case, we are having both direct and indirect bilirubin will be there. It gives us biphasic reactions, means both, because both the bilirubin are there, so two phases reaction will occur, one for direct, other one for indirect. So overall we are having biphasic reaction. And third type of jaundice is going to happen, which is caused any kind of abnormality after the liver. Means bilirubin, which is conjugated here, is going to be transported from bile duct to the intestine. So if we are having any kind of obstruction, any injury, any swelling, any inflammations, any gallstones, or any defect in the bile duct, by which those conjugated bilirubin unable to transport it to the intestine, so that this will be leak out from those bile ducts. So here only conjugated bilirubin leaking, that is because of obstruction, because of any kind of haltage. So this is called as obstructive jaundice, or it is called as post hepatic jaundice. In this case, only conjugated bilirubin rises, so it gives you only direct reaction. So hepatic jaundice can be of three types: either prehepatic before liver, hepatic due to the defect in the liver, or post-hepatic due to the defect in the bile duct, or hemolytic jaundice, hepatocellular jaundice, or obstructive jaundice. Now, this sorry. So this Van der Waals reactions is useful in the understanding of nature of jaundice. This is due to jaundice is characterized by increased serum concentration of unconjugated bilirubins. That is called because of hemolytic jaundice, when more RBC will be degraded, or conjugated bilirubin, which is caused due to obstructions, any kind of defect in the bile duct, or both conjugated and unconjugated during the hepatic jaundice. So we are having indirect positive test in case of hemolytic jaundice, because we are having only unconjugated bilirubin there. So only indirect positive test. In the case of obstructive jaundice, where we are having only conjugated bilirubin, so it will give you only direct positive test. And in case of hepatic, we are having both type of bilirubin there, so it will give you biphasic reactions. So on the basis of different types of van der Waals reactions, either we are going to get direct, indirect, or biphasic, we can differentiate which type of jaundice we are going to have. Bilirubin in urine. This is how bilirubin, serum bilirubin is going to be estimated. We can have different type of tests for urine bilirubin also. Like we can have Fouchet test or we can have Mellin test. So how result is going to be interpreted? If we are going to have unconjugated bilirubin level rises, that is unconjugated means indirect bilirubins. This is going to happen in hemolytic anemia, any kind of liver disorders, cholestasis, or in case of fasting in horses. Conjugated bilirubins, which is direct bilirubin, is going to be increased in case of extrahepatic, means outside liver cells, bile duct obstructions, or biliary ruptures, or any kind of gallstones. Total bilirubin rises either due to increased production of unconjugated bilirubins, decreased uptake by the liver, decreased conjugation, or cholestasis. So these may be the different reasons. So on the basis of which type of bilirubin you have identified, you have detected during the van der Waals test, you can identify which type of jaundice is there. Now we are going to see second test, that is urine bilirubin. So normally bilirubin in a normal healthy human being, humans urine, bilirubin should be absent. So there should not be bilirubin present in the urine, and its presence in the urine indicates any kind of abnormality in the liver. And if it is going to present, it is only the conjugated bilirubin will be present in the urine. No unconjugated bilirubin can be found into the urine, because unconjugated are water insoluble, so it cannot be excreted. So only conjugated bilirubin is water soluble, so only conjugated will be excreted into the urine. And conjugated bilirubin, you can say this is going to happen either in case of hepatic, where both bilirubin rises, or it will be in the obstructive jaundice, where uh, only conjugated bilirubin rises. So this, if conjugated bilirubin can be found in the urine, it means they are having either hepatic or obstructive jaundice. This urine bilirubin can be detected by a Fouchet test. So we can see what is Fouchet test. In the Fouchet test, we have barium chloride reacts with sulfate, sulfate which is present in the normally in the urine. So this BaCl2 reacts with the sulfate of urine and forms barium sulfate. If bilirubin is going to present now in the urine, so bilirubin will be adhere with barium sulfate and precipitate. First, without involvement of bilirubin, barium chloride, which is present in the solution, present in the reagent, reacts with sulfate of urine, forms barium sulfate. Barium sulfate, if bilirubin now there, this barium sulfate adheres with bilirubin and precipitated, and is detected by the oxidation to form biliverdin, which is of green color, along with ferric chloride FeCl3 in the presence of TCA, trichloroacetic acid. Now, when we are going to add nitric acid, it oxidizes bilirubin to biliverdin. So this green color, if we are having bilirubin here, which will be oxidized by nitric acid, and gives a different color from green to violet. The Fouchet test, how we are going to perform? So we are going to take 5 ml of 10% DaCl2 and 10 ml of urine and mix them, and then if precipitate forms, we are going to use on the filter paper, it will be filtered out. So precipitates will be on your filter paper, and then on filter paper we are going to add few drops of Fouchet reagent. This Fouchet reagent contains 10 mg of FeCl3 and TCA, trichloroacetic acid. And if green color appears, means bilirubin is there, means bilirubin has been converted into biliverdin. So this conversion gives us information about presence of bilirubin in the urine. Another component which we are going to detect is that is urine urobilinogen. Urine level presence of urobilin in the urine depends on how much bilirubin reaches to the intestine. because this urobilinogen is only coming to the kidney. So if more amount of urobilinogen will come into the kidney, into the intestine, more will reach into the kidney. If less amount of urobilinogen coming to the intestine, so only less amount of urobilinogen will be in the kidney. So this level, urine level, depends on how much bilirubin reaches to the intestine. And this urine level of urobilinogen is going to be detected by semi-quantitative Ehrlich test. What is the principle of this test is para-dimethyl aminobenzyaldehyde, which is in the acid medium, reacts with urobilinogens to form a pink color substance at room temperature, that is roughly 22 to 26 degrees centigrade. In this case, we are going to take 5 ml of fresh urine in a test tube and add 5 ml of Ehrlich reagent. This is the Ehrlich reagent. Wait for 10 minutes and add 10 ml of saturated sodium acetate solution, and then observe the color. A pinkish color indicates the presence of urobilinogens. This urobilinogen is present in the urine in case of only hepatic and pre-hepatic jaundice, because in case of post-hepatic jaundice only we are having conjugated bilirubin, so that will be excreted. So urobilinogen is present in the urine, that is only in the hepatic and pre-hepatic jaundice, that is hemolytic jaundice. It is present in excess amount in pre-hepatic jaundice and is completely absent in post-hepatic jaundice. As I have told you, whether only conjugation will be there. So these are the three different tests we have seen: serum bilirubin, urine bilirubins, and urine urobilinogens. So if we say serum bilirubin, we have two types, either conjugated or unconjugated. The normal level of those things is serum bilirubin 0.1 to 0.4 conjugated, 0.2 to 0.7 unconjugated. Urobilinogen's normal level is 0.4 in 24 hours, and bilirubin is normally absent into the urine. In case of hemolytic jaundice, conjugated bilirubin is normal, unconjugated is going to increase because more RBC is going to be degraded. Similarly, urobilinogens, in case of hemolytic, it is going to be increased, as we have seen, and urine bilirubin is going to be absent. Hepatic jaundice, where conjugated bilirubin rises, unconjugated also rises, because in the liver we are having both conjugated and unconjugated. Urobilinogens may be normal, may be decreased, and this urine bilirubin may increases, because here conjugated increases, so it may present into the urine. Similarly, in case of obstructive, only conjugated bilirubin rises. Unconjugated will be normal because it is obstructive. Urine, this is post-hepatic jaundice, so here urobilinogens will not be there, it will be absent, and bilirubin level will rise. So this is the comparative how we can analyze different components, either bilirubin, urobilinogens, or bilirubin in the urine in different kind of conditions. So hope you have understand it. If you have any query, any comments, you can write in the comment box. If you have not subscribed my channel, please subscribe it. You can ask me any question anytime. So next day we will upload the next few video on the liver function test. Thank you very much. Have a nice day.